Good evening, everybody. We welcome you to this wonderful webinar, The Talk Inherited Mutations. My name is Lexa Jett, and I'm with ANCAN. We want this to be as interactive as possible, and so if you look to part of your screen, you can see an area where you can ask questions, and please do not hesitate to use that function at all. We want to hear your questions, and we would love to answer them. We have a lot of people with different perspectives. The only thing we ask is that you keep them general and non-medical, since we cannot offer medical advice. I'm going to hand this off to our founder, Rick Davis.
Good evening, everybody, and welcome to this very first webinar for 2021. We have, I think, 10 more or 11 more planned. I'll come back to that, but first of all, I just want to tell you a little bit about ANCAN. If you don't know us, we provide support, navigation, and advocacy. And we were probably the first people to offer virtual support, live interactive virtual support, as far back as 2010, in the ancient days of conference calls. And we moved to this video chat format in 2015. So long before you'd ever heard of COVID, we were running video chat support groups. We now do that for 20 groups, about 20 plus groups, about 10 plus conditions, and we host somewhere around 10 webinars a year. This is our second, this is our fourth in the series of the talk. We did 3 talks last year, one for prostate cancer, one for ovarian cancer, and one for multiple sclerosis. And this year we are hosting this and the second one later on in the year on blood cancers. And I would in particular like to dedicate this webinar to the memory of somebody who was very important, not just to ANCAN, but to me personally. My dear friend, whose photograph I keep right here, my dear friend, Professor Bill Burhans, Dr. Burhans, who we lost about 1.5 years ago now, and who was BRCA positive, and who wrestled with his family over these BRCA positive issues. And I worked with Bill at the time, and we to try and set up better support for families who carry an inherited mutation. And this webinar is our first step. We hope to move from here, maybe working with FORCE and Charcheret and UCSF, Center for BRCA Research, to see if we can't get some dedicated virtual support groups, video chat virtual support groups. I do want to say, if you'd like to attend any of our webinars in the rest of the year, please sign up on our mailing list for on the webinar, and we'll keep you posted as to what's going on. I want to thank our partners tonight, namely FORCE, Charcheret, the UCSF Center for BRCA Research, the James at the Ohio State University Comprehensive Cancer Center, National Ovarian Cancer Coalition, and also Bagot. And I also would like to just acknowledge ANCAN's sponsor, Myovant. Hopefully we'll be adding a few more names to Myovant by the time we get around to our next webinar. I think that's all I have to say for the introduction. So I'm going to turn this over to FORCE and to Lisa Schleger, and we're going to spend a few minutes informing you about FORCE and then about Charcheret, and then we'll get into the meat of talking to the pairs. So Lisa.
Thank you, Rick. What a nice introduction. So I think somebody's going to be pulling up slides for me. Yes. Oh, show my screen. Okay, I guess I'm pulling up slides. Let's see. So, okay, hopefully everybody can see that. So again, my name is Lisa Schlager, and I'm the Vice President of Public Policy for FORCE. FORCE stands for Facing Our Risk of Cancer Empowered. And we were established in 1999, so we've been around quite a while. Specifically to serve the hereditary cancer community. At the time, that consisted of just BRCA1 and BRCA2 mutation carriers, or at least that we knew of. Obviously, we're in a very different place now, and FORCE has since expanded its mission to really represent individuals from any background that have any type of hereditary predisposition to adult onset cancers. So we're talking about mutations including BRCA, but also ATM, CHEK2, PTEN, Lynch syndrome. These are all mutations that cause increased risk of cancers. The most well-known cancers associated with hereditary cancer are obviously breast and ovarian. People like Angelina Jolie have raised awareness of that. But what a lot of folks don't realize so often is that many other cancers are associated as well, including prostate, pancreatic, colorectal, and endometrial cancers. So we serve that entire community and really strive to meet the needs of the individuals who face these hereditary predispositions and or the actual cancers themselves. So a little about our history. Our founder, Sue Friedman, was diagnosed with breast cancer at age 33 in 1996. So that was really the very beginnings of when they were starting to test for BRCA mutations. And she wasn't really aware of her familial risk, never really talked about cancer in her family. But she had a medical background. She was actually a veterinarian, and she started reading some articles, and all of a sudden some red flags went up because she realized that looking at her family history, there were some red flags for hereditary cancer, and perhaps genetic testing was appropriate for her. It was such a new thing though. So in 1997, the following year, she started asking some questions and ultimately was referred for genetic counseling and testing and tested positive for a BRCA2 mutation. And she felt a little frustrated at the time that nobody had suggested testing. But again, it was so new, and she was a very proactive individual. But with that knowledge, she also felt that she might have made some different choices with her treatment and surgical decisions had she known about this hereditary predisposition and the implications of it, that she was not only at risk of the breast cancer that she was fighting, but also ovarian cancer, and that this would also affect other family members and her children. So a couple of years later, she founded FORCE, specifically to fill that void of information and support for people like her, because she went to, for instance, a breast cancer support group, and a lot of them were in a different position than she was. They were older. They weren't also concerned about ovarian cancer risk and family members. So FORCE was really her way of helping herself, but also connecting with others. And ultimately, she left her veterinary practice about 5 years later and relocated the organization to Tampa to align with the Moffitt Cancer Center at the time so that she could work closely with researchers on hereditary cancer research. And we still work closely with Moffitt even today, but we work with a lot of other medical institutions around the United States, some of the top cancer centers in the world, to help facilitate additional research around hereditary cancers and the medical options and care that are available to people with mutations. So this is just an overview of our programs. And as I said, we initially started out just providing information and support. But over the past 20 so years, we've grown to a nice sized staff of about 14 full-time. And we offer basically 4 pillars of services. So support, which is still really the underpinnings of everything we do. It covers both peer navigation as well as we have a helpline. We have local support coordinators in every state, and we have virtual message boards. We used to hold in-person meetings. We've had to transition to all virtual as a result of COVID, but it's actually been very effective in a lot of ways because you used to be limited by where you lived as to which support group you participated in. Now we can do support groups specifically for men, for instance, or specifically for what we call previvors, no matter where you live. And so it facilitates connections that you know, with people who have similar concerns, people who are fighting cancer or people who are, you know, at high risk but haven't had cancer. So it really enables us to customize those support meetings to the individuals who are taking part. The other big part of what we do is education. There's a lot of information out there. Not all of it is accurate or evidence-based. So we really pride ourselves on providing the broadest and most comprehensive library of information on hereditary cancer genes and their implications. Our website is updated practically daily with new information. We do tap into the National Comprehensive Cancer Network for guidance on what the appropriate management is, for instance, for someone who should be screening if they have a mutation. But we have a variety of things, including comprehensive information on the website. We've historically held a rather large conference, which is moving virtual this year for people affected by hereditary cancer. It's the largest conference that we know of in the world for patients affected by hereditary cancer. We also have a program called X-Rays that looks at the headlines in the news and evaluates whether those headlines are accurate and the research that they're talking about was well done. And we have also customized decision guides for people trying to make decisions around their mutations, what types of surgeries or interventions or screenings they might consider, what types of treatments might be best to really facilitate informed decision making. As I mentioned, we are involved in research. We don't fund research, but we're very active in collaboration with researchers around the country and around the world. And we also have research advocates. We train advocates to help represent our community and work with those researchers to make sure that the interests of the community are represented. And finally, my area of passion is the advocacy and public policy. So we really are the only org that specifically represents the public policy and legal needs of the hereditary cancer community. We work mostly at the federal level, although we do get engaged at the state level as well. And a lot of what we do is focused on access to care, trying to make sure people can get access to the services they need, whether they are insured or uninsured, whether they have Medicaid or Medicare. We also do a lot around genetic privacy and protections. So if you have questions about what your rights are if you have genetic testing or if you have a mutation, that is something we can help inform you about. And device safety as well for women specifically. If you're, say, getting breast implants as a result of a mastectomy, you want to make sure those devices are safe. So we get heavily involved in all of those types of things, and we're pleased to share that work with the community and to represent the community. Going back to support, because I really do think that is one of the most important things that we do. This is just a snapshot of our website and the different types of support we offer. So if you were to go to our website at www.facingourrisk.org, you would have the option to click on one of these and get information. And as you see, there is a section on insurance and paying for care, but also on finding healthcare providers and getting peer navigation or local support meetings. So we're very proud to offer a variety of services to support people in their journey. Drilling down to that peer navigation, for people who are interested, we will match you one-to-one with somebody who is very similar to you. So for instance, if you're a 45-year-old man with metastatic prostate cancer, we are going to do our best to match you with somebody very similar who can provide you with a customized resource guide on topics that are of interest to you. So you might be interested in what your treatment options are, how to communicate with your family, because this really is a family issue. When you have hereditary cancer or you carry one of these mutations, it's not just you, it's your siblings, your parents, your children, your cousins, your nieces and nephews. And so we try to support the entire family, the individual with the mutation, but also the spouse and the family members as well. So communication is so important, and we do offer resources on communicating with your family about these mutations. And not everybody handles it the same way. So we offer resources on how to handle that as well. It can be frustrating sometimes if one person doesn't want to get tested, or you know, they want to keep private about it while others are more interested in sharing. These are all very typical responses from families, and no one family is the same. So we really try to help with that. As I mentioned, there are laws that protect individuals who have mutations or even family histories of disease. The Genetic Information Non-Discrimination Act is really important. It specifically protects people with mutations from discrimination in health insurance and employment. What's interesting is it does not apply to life, long-term care, or disability insurance, but some states have enacted stronger laws that that cover, cover these types of insurance as well. So we do have information on our website about this, and I am available to answer questions should anybody have them. And that's sort of the quick overview of the resources we offer. And as I said, we have many mutations now, and they may seem different in certain ways, but the basic foundation of hereditary cancers are the same, and the psychosocial needs are the same, and that is what FORCE strives to address. So we're here for the community, and we take pride in what we do. And I will also add that the majority of our professional staff are personally affected with mutations, so this is personal as well as professional. Here's some more information on where to find us. And I've added my personal contact information in case anyone would like to reach out directly. So thank you.
Thank you. Thank you so much for that introduction to FORCE. They are truly a force in the field of inherited mutations, and please do not hesitate to reach out to them if you need more support than what you're currently getting. I would like to turn this over now to Melissa Rosen from Charcheret, and another important organization that is doing some wonderful work to support folks with inherited mutations. The floor is yours, Melissa.
Thank you so much, Rick and Lisa. It was great seeing you. So my name is Melissa Rosen, and I am the Director of Training and Education at Charcheret. Charcheret is actually a Hebrew word which means chain, as in we're all links in the chain of support. I'm proud to say that we work with FORCE and many other similar organizations. Charcheret is a national nonprofit organization that provides free psychosocial support to women and families who have been directly impacted by breast or ovarian cancer, but also anybody who is at greater diagnostic risk because of a family history or a known mutation. And just like Lisa said, we started out really just focused on BRCA mutations, but at this point, our support is for the mutations that were on Lisa's slide, as well as others. And again, our programs are open to anyone, men, women, and that's important to keep in mind. So there are two things that Sharsheret does. It's a great way to look at it as almost two buckets. So one is our education and outreach, and we do this across the country with communities where we teach them how to educate themselves about their family history, where we talk to them about living well in general and how to be proactive and to take control of their health. We also train healthcare providers as well, and I'll talk a little bit more about that in a moment. And then we have our support team, which consists of social workers, licensed clinical social workers, as well as an amazing genetic counselor, and they are available 9 to 5 in every time zone to take calls. Sometimes those calls are just to connect someone to a resource. Sometimes they're to listen to a person vent. Sometimes they're to explain test results, particularly with our genetic counselor. And those calls very often turn into relationships. But we also have a series of formal programs to help people navigate the cancer experience, anything from prior to a diagnosis to long-term survivorship. And those programs include things like peer support, as well as an amazing program for families raising young children while dealing with cancer, or that's our Busy Box program. Our version of a survivorship kit is a survivorship program is our Thriving Again kit. We have a program for caregivers, a program for those facing metastatic disease. We have a program to help people deal with the cosmetic side effects of treatment. And of course, we have our genetics program. We have a full-time genetic counselor whose services, just like all the rest of ours, are completely free. She schedules half-hour calls for a variety of reasons to help someone determine whether they need further screening, to answer questions years after a screening about whether additional screening is needed. We do something very unique called family conference calls, where once the person has the results, everyone from the family can gather on a call, and our amazing our amazing genetic counselor will really explain what the results mean and how those results impact those people on the call. That's an amazing opportunity. She also helps people deal with the emotional impact of carrying a genetic mutation. So amazing opportunities. Again, all of them free, all of them completely confidential, and all of them really customized to an individual's direct concerns, needs, and very personalized. I actually want to spend some time sharing a story of the story of one of our callers, because it's a really great example of the kind of calls we get and the way we help people. So we have a pretty recent caller who during the pandemic was trying, because it was time to get her annual OBGYN appointment, and her doctor's office was being non-responsive. So she picked up the phone and made an appointment with a new doctor. Her mother had been diagnosed with breast cancer at a young age, and so this caller, our caller, was very responsible and had genetic screening and had been told by her original doctor that in fact she was in the clear, that the test results came back and she had nothing to worry about. but it was still time for her annual, and she knew that with a mother who had been diagnosed early, she shouldn't be putting it off. And she did get an appointment with a new doctor who took a full history and said to her, you know, you have very dense breasts and a family history, and I don't think my exam is going to be enough. I'm not comfortable doing that. I want to send you to a breast surgeon and to do an exam. And by the way, I'd like to see your medical records from your past doctor. So she made an appointment with a breast surgeon for a regular breast exam, and she had her results, all of her medical results, including her original genetic screening, sent to this new OBGYN as well as to the breast surgeon. She did have a physical exam and everything felt fine. However, both the breast surgeon and the new OBGYN said, but your genetic screening came back that you have a mutation. Why is it you thought you didn't? And after quite a bit of research and investigation, her original doctor was checking for BRCA mutations, of which she did not have. In fact, she had a different mutation, and it wasn't one of the more common ones. And the original doctor never thought to look. And now she has two doctors, her breast surgeon and her new OBGYN, telling her she needs to start thinking about prophylactic surgery and all sorts, and talking to her family, and all sorts of things came on very suddenly. Nobody could explain to her why her original doctor hadn't picked up on her CHEK2 mutation, what that meant for her, what type of surgery she should be having. And again, once again, her biggest question, which is why wasn't this addressed? And one of her friends realized she was struggling and told her to call Sharsheret, where she scheduled an appointment with our genetic counselor, who actually went through everything with her, spent quite a bit of time with her, explaining, based on her exact results, why it is her original doctor may not have realized the importance of this CHEK2 mutation. She learned what it meant for her siblings. She learned what she should be thinking about doing. Again, we don't offer medical advice, but we'll frame the issues so that you know what you should be thinking about. She actually responded to us saying that Sharsheret was the first conversation she had had. Nobody had even suggested to her until she called Sharsheret for some emotional support that she should be talking to a genetic counselor. And so speaking to our genetic counselor really explained so much, and she went forward with her decisions with a full understanding and confident she was making the right decisions. So, you know, I just want to point out a few things about that story. Those stories are actually kind of common that we get, and the lessons that we take away from that are a few. One is that we always, as patients, need to advocate for ourselves. If we don't understand things, we need to ask questions. If we're not getting the answers that make us comfortable, that at least we feel that we understand and point us in the right direction, perhaps it's time for a second opinion. Bring a genetic counselor in, bring a different doctor in. Those things are incredibly important. And again, the assumption, you know, Lisa mentioned that when Sue, Force's founder, was diagnosed, nobody suggested genetic testing. There's a good chance that if someone's diagnosed, genetic counseling today in 2021 will be recommended, but not a lot of, that doesn't mean that the doctor you have knows how to read those tests or knows exactly what tests should be ordered. And that's why it's so important to get a knowledgeable doctor or a genetic counselor and a genetic counselor involved. And I think those are some really great takeaways. Again, Sharshera's genetic counselor is always available. We also have a lot of educational resources, including a relatively new one, which is How Do I Tell My Children About My Cancer Gene? It's a great brochure with a lot of great information, again, not just about BRCA, but about the other mutations that people currently screen for as well. My suggestion to you, if you'd like more information, is to reach out to me, which is mrosen@sharsheret.org, or to check out our website. I'm going to spell it simply because Sharsheret as a foreign word is a hard word to spell in English. So my parting thought will be our website address, which is www.sharsheret.org, SHARSHERET.org. Thank you very much. And Rick, thank you very much for this event. This is an amazing opportunity for people to learn more.
Thank you, Melissa. And we have put in the chat window for everybody some links for Sharsheret and for Force. And now, talking about genetic counselors, I have the great privilege of introducing to you a genetic counselor who came to ANCAN's attention earlier this year because echoing Melissa, she did an amazing presentation for one of our prostate cancer groups. And so when we came to think about inherited mutations and who would be a great moderator, we thought, oh, let's ask Lindsay Byrne. Now, the most important thing about Lindsay Byrne is that she's never seen a St. Louis sports team that she doesn't like. Oh, no, I'm sorry, I was supposed to leave that to the end. How about St. Louis City? That's the new soccer. There's a new soccer franchise, St. Louis City. Are you going to be a fan of St. Louis City? I don't. We'll find out. No,
we'll talk at the end. We'll talk sports at the end for if others want to get off.
So now the serious stuff. Lindsay received her Master's of Science degree in Human Genetics from Sarah Lawrence College in 2008, and she's worked her entire genetic counseling career in the field of cancer. In 2018, she established a genitourinary cancer genetics clinic at Ohio State University, where she sees patients and their families with prostate, kidney, and bladder cancer. Lindsay's highly involved in the OSU Genetic Counseling Training Program as course director, supervisor, thesis committee member. She's on the admissions committee. She's also an assistant professor. And she holds all kinds of Ohio State offices in the Genetic Counseling Association, etc. And on a national level, she's involved with the National Society of Genetic Counselors and is the current co-chair for the Cancer Special Interest Group. Can we talk sports now? Oh no, I've got to wait till the end, right? I've got to wait till the end for that. So with that introduction, I'm going to turn it over to Lindsay for the next 40 minutes or so, and we're going to spend about 10 minutes with each of our pairs. And if you have any questions that arise, please put them in the Q&A window, and we will funnel them back through Lindsay to the one of the four pairs or all of the four pairs. Lindsay, you're in charge.
Lovely. Thank you so much for the introduction. And I have to say, I'm so excited to be here tonight and that I found my way to ANCAM, or they found me, and I get to be involved and be in this event. I mean, this is my passion, to help patients and families navigate the complicated world of genetics. And so with that said, I want to get to the real stars of this show and talk about, families that this really affects and changes and impacts. So with that said, I want to introduce our first set our family, mom and daughter, and that's Alana and Razi. And hopefully you guys can come on video. Hello.
Here we are.
Well, hello. I love to see all the smiles. I first off want to give you guys a moment to introduce yourself and give us a little bit about your guys' relationship and how cancer and how genetic testing has either changed your relationship or impacted it. And I know that's a lot to start, but I want to give you guys the floor to share a little bit to start with.
I'm Razi Brilliant. Alana is my daughter. In 2012, I was diagnosed with ovarian cancer. At that time, and for many years before that, my mother died at the age of 47. At that time, we were told that it was colon cancer. My grandmother died at 53. We were told that that was women's cancer. You're talking 70 years ago, 70-some years ago. So who knows what, for each one of them, if that was really true by today's standards. I was always concerned that there was something, a predisposition to something, and unfortunately it was true. What I felt in my gut turned out to be medically the truth. And so I was diagnosed. After a few treatments, my oncologist suggested that I meet with a genetic counselor because of my family history, along with my mother, my grandmother. My father died of cancer. His sister died of cancer. My uncle, my mother's brother, died of cancer. My own brother, who is still alive, has had 4 different kinds of cancer. So it is everywhere in my gene pool. And so my oncologist suggested that I go for genetic counseling. My children, my daughter and my son went with me because they had a vested interest, and they also wanted to hear everything for themselves and for me. It's always good to have another pair of ears. And so we all went, and walking out, my daughter said to me, "Ma, if you're BRCA positive, I know I am too." Well, the long and the short of the story was, eventually she, a year later, she got tested and she was BRCA positive. As far as from the genetic perspective, one of my big angst is that you were talking about in 1996, they were already doing genetic testing. And, you know, at the time, well before 2012, when my cancer was discovered, every doctor that I went to, they were all changing over their record keeping systems, and everything was being electronic. And every form I filled out said, what is your family history? Mother, father, cancer, heart, da, 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 da. There could not have been one doctor or one person who ever looked at that and could not have seen my family history. So I'm thrilled that today, through advocacy and everything else, that the doctors are more informed. They are looking into it. I know my own doctors, they always say to me, "Don't worry, Rosie, we're on it." You know, like when we see things now because of you, we've got a different pair of eyes. And that makes me feel good, so that my situation might not happen to someone else. Had someone sent me for genetic testing, I would not have been afraid, okay? It answered all my questions and all my fears for all those years as to whether there was a predisposition. So you know, to answer your question, I was diagnosed basically, it's a little over 8 years ago at stage 4, which is not uncommon for someone who has ovarian cancer. And I have been blessed to still be alive. And it's all thanks to medicine and technology.
So if I can just kind of follow up on that, because she knows that she has a genetic predisposition, it opens up a lot of opportunities for her for treatment, namely in the PARP inhibitor. So I just wanted to point that out, but I do want to share a little bit about me. Because of her BRCA status. As she said, I knew if she had it, I had it. I just felt it. And of course, I did get tested and I carried the same mutation. But because I had been with her to a genetic counselor, I knew that the way to reduce both breast and ovarian cancer was to remove my ovaries premenopausal. And of course, I went ahead and I did that. I met with a gynecologic oncologist. I did everything ahead of time. I did a CA-125, the blood test. I did a vaginal ultrasound. Everything looked normal. And then on the operating table, they found that I already had stage 2 cancer. So if it were not for having known that I had a genetic mutation and that I had gone for surgery, I'm certain that I would have been diagnosed at a much later stage. And speaking of the PARP, at the time that I was diagnosed, it was still in clinical trials. And the only way that you could get it as a participant was to have had 3 lines of chemotherapy. So at the time, neither one of us really qualified for it.
Right. And actually, the first conference that we went to at Johns Hopkins, they put up and they talked about this is the futuristic, the PARP inhibitor. And I am on a PARP inhibitor now and have been for a few years. And so that's why I say, because of technology and knowledge and everything else, I am a big advocate and keep telling people there is so much hope for us if you just get the knowledge.
Thank you, ladies, for sharing that. And I'm really glad you brought up, treatment discussion and about PARP inhibitors, because that truly is the groundbreaking piece of learning this information and the steps towards personalizing our medicine, right? And knowing that we all won't get the same type of treatment because we know that each of the cancers interact differently. You're going to say something. Go ahead.
Yeah, I was. One of the other big things that Alana and I both agree about is that I have a son. And so, and I do a lot of volunteer work. And at one of the charity events, this gentleman came up to me with tears in his eyes. He could not hold them back. And he said to me, I'm the one who gave my daughter ovarian cancer. I'm the one who carried the genetics. So I think it's very important for people to understand that although we think of the genetics being passed from, especially with breast and ovarian, from mother to mother, it can be from father to daughter. And most people don't know that.
That is absolutely correct. And, again, I've been doing this for a long time, but every time I do any type of presentation, whether it's to physicians or providers to the public, I have certain myths that are on my slide. And one of them is, you can get female cancer from your father, or you can get male cancer from your mother. And because that people still think that and believe that. And, I still educate, listening to the stories at the beginning of this, I still educate providers to see family histories like what you're saying when you fill out those forms, and we fill them out every time we go, and they still aren't thinking or doing anything with them or having conversations to offer that option. So as you are doing advocacy work, I continue to educate, and I think we just need to keep our voices out there until we can continue to make sure that everybody has that opportunity to get themselves to the right information.
Right. I have participated. I live in Maryland, and I actually went to Annapolis. It's just about a year ago, because in Maryland, genetic counselors can only be in practice under a physician. They're not allowed to have their own businesses. And so I went to advocate with them. That's where I met Lisa.
Lovely. I love the support.
to try to see that we couldn't, because all these underserved areas where they're not associated with the hospital, look how many people are not getting information.
Right. No, that it is a problem. We, don't have enough specialists to cover that. And, the thing that I try to think about is making sure that when physicians are trying to take this type of information on, as long as they understand it and know the complexities of it, I don't feel like everyone has to see a genetic counselor. The issue is there are people who are functioning as trying to do genetics information and don't understand the complexities of it. And that's when you need to reach out to specialists to help with that part. So let me ask you guys a question in regards to, do you feel like as mother and daughter, your relationship changed when you found out you had a BRCA mutation in your family, or did you feel like everything has been really more the same, or is there anything that you felt like changed?
I'd like to address that, and then Alana can say her part. When I found out I had the BRCA mutation, I could accept it. It was fine. When she went in and she had the BRCA mutation, and then she had the surgery, I cried unbelievably, and I'm not a crier. I felt so guilty, and she kept saying to me, "Ma, it's not your fault. I'd be angrier with you if you didn't go for the testing, because then where would we be?" And so, she's a sweetheart. But we've always had a very good relationship. And there's certain things that, like in our journey, our cancer journey, where I may have experienced it before her, or she may have experienced it before me. So we've shared so much. And both of us, our passion is to try to go out there and help people, in any way that we can.
Yeah, I don't think it was clear, but because of her diagnosis, then I was tested. So we were both diagnosed with ovarian cancer within a year of each other, which is crazy. 1 year for both of us to be diagnosed. So it's hard to know what was the mutation and how that changed our relationship, and what was cancer, because they happen so close together. But obviously it definitely did change our relationship, and we do a lot of speaking like this to educate people out there.
What is something, and this is more me from a genetic counseling perspective, and you can share it in regards to as a patient too, what is something that you feel like you could share with your genetic counselor that you think would be more helpful for future patients, like how he or she gave the news, or if there's anything that you could share with me to make things better for future patients, I would love to hear.
Again, I do a lot of volunteer work and things like that. And I have so many people who call me and they'll say, "Could you talk to my family member and convince them to go for genetic counseling? They're afraid." And, and because I am the kind of person, and Alana as well, that believes that knowledge is power, that is what saved our lives. I try to explain to people that, yes, but, we all know that there are some of us who want to know and want to plan our lives. And there are some people who, whatever happens, they're going to deal with it. And unfortunately, it's very difficult. I say I'm happy to talk to the person. I'm happy to try to tell them that, you love them and you want them to do this. It's for them, it's for you, it's for the children, the next generations. But if someone is of a mindset that they don't want to do that for their fear, it's real. That I find is the hardest part, is to overcome people's fear, when I think completely the reverse. Like without that knowledge, where would we be?
So you were asking, what you as a genetic counselor can do, and you said that you educate physicians, and I think really, from my perspective, that's the most important thing you can do, because again, having ovarian cancer, we know that 20 to 25% of ovarian cancers are genetic, or hereditary, I should say. And according to the NCCN guidelines, every woman who is diagnosed with ovarian cancer, regardless of their family history, should be receiving genetic testing. And that's about 30% right now of the women who are diagnosed with ovarian cancer. And I think if you reach the doctors first and educate them that they should be sending their patients for genetic testing, I think that would make a huge difference.
I think mine is a perfect example of that. Every form I filled out, no one paid attention to it.
Yes. No, and I think that is a lovely take-home message to continue doing the work you guys are doing, continue to educate. I did a study that looked at patients being referred across the entire state of Ohio and that looked at ovarian cancer, it should be 100%. 100% should be, you know, getting testing or getting counseling. It's still barely over 50, 60%. What's happening? Like, it's so straightforward, right? So we're not done yet. We still have a lot of work to do, unfortunately. So I'm glad that you guys are here to continue to share your message. Any last minute things you would like to share with the group before I meet my next family group?
I don't think so. I feel like we covered everything.
Okay. We'll probably hear from you more just as we get some more question and answers. But thank you, ladies, so much for sharing your story and spending a little bit of time with me today.
Thank you for letting us tell our story. As my daughter always says, this is therapeutic for me. It's not for her. I love telling my story because I feel like every time I tell it, if I help one person and it's done something for them, then it's made me accept the fact that I had cancer.
I do see that somebody here a comment about better coverage for genetic testing. And to be honest, because my genetic testing was so many years ago, I don't know what the coverage is. I do know that I only got tested for her single mutation. And back in 2013, I had to pay $700 out of pocket for just that one mutation to be looked at. She got the full panel, but I did not. And so I think
so I can comment on that. Yep. So I think the great news is that I now order up to 77 genes and plus at once, and most of my patients pay less than $100. And if insurance doesn't cover it, or, you know, because I will offer testing pretty much to anybody who comes, even if they don't meet like NCCN guidelines or, you know, testing guidelines, because my view is if somebody wants to have information, why should I be that barrier as long as I can help them through it and explain it? Self-pay for testing now with that many genes would be $250 straight up. So we've come a long ways from when I started testing, just looking at BRCA1 and 2, it'd be $5,000, about $5,000. So it's not zero, but a lot of times it is zero when I do use insurance. So I feel good about where we've come from where we were. So hopefully that helps answer that question.
Yes.
All right, ladies.
Thank you.
You're welcome. Okay, I'm going to switch gears over to Peter and Joel. Are you guys still here, hanging on?
Hello.
Hi,
Hello.
Joel.
Hi there.
Is Peter still here? Is Dad still here? Hey, Peter.
Hi.
Okay. Well, I'm excited to talk to a dad-son duo because, as we know, all family relationships are a little bit different. And I would love it if you guys would share a little bit about yourself and tell me about your genetic journey.
Okay. We are not only in different parts of the country, we are in different countries.
Oh my goodness.
Joel's up in Edmonton, Alberta.
Canada.
And I'm down in Maui, Hawaii, which is paradise until you get sick. Then
oh no.
California's paradise.
Yes,
Okay.
I can understand that.
So just briefly, I was diagnosed with an aggressive form of prostate cancer, advanced prostate cancer, about 7 years ago. And as I said, Maui or Hawaii is not the place to have a serious disease. So I made my way over to California, to UCSF for treatment initially. And I found a great oncologist down in Southern California. Anyway, I've been going back and forth to the West Coast quite a bit over the last number of years for treatments. One of the great advantages of a center of excellence like UCSF is that they had a whole genetic counseling outfit there. So I participated in that back in 2017 or so. Just to, because I know my dad died of prostate cancer, and I just wanted to kind of put pieces together. He was no longer alive. I don't have any family records of genetic history or anything like that. But so lo and behold, it came back with a what's called a Lynch syndrome mutation. The specific gene was MSH6. I should make a T-shirt with that, which is not a big indicator for prostate cancer. I think about 16% of men with prostate cancer have a genetic mutation that might be driving it. And of that 16%, only 1% of those might be driven by the MSH6. So, so I don't know if that's what's driving my prostate cancer, but it's interesting. So I communicated. I've got, besides Joel, I have a younger son. Both my sons are in their mid 40s, and Joel will tell you that I was on. You know, they're no longer children, so I can't tell them what to do. But better believe that I told them everything I was doing, and made sure that they had all the latest and greatest information.
And how did that go, Joel, when he had that conversation with you? How did you take that, and how did you utilize that?
Right. It went well. This is a lot of this is still learning for me. I actually I certainly had no issue with it. However, I also wasn't motivated to start getting genetic testing myself, and I'm still. It actually maybe and I know I can't say I was seriously motivated to look into testing to see if I had mutations until maybe this actual web seminar that we're doing, or web thing that we're doing now, inspires me maybe to check, but I'm still learning. I guess I'm just trying to wrap my head around I guess my sense is that probably everyone has some sort of mutation, and so so I guess I'm just trying to wrap my head around what to look for and how serious it is, and also in Canada how to navigate that. And so I'm at the beginning with all this, but I certainly have no issue hearing what my father's been through, and I'm supportive of that.
So what I'm hearing is you are still contemplating whether you want to know whether you're positive or not. Is that correct? So you're in that process of trying to decide if you want to test?
Well, I'm not afraid of the testing per se. I guess I would I'm just kind of gathering information as far as what is involved in testing, what sort of genetics I would be testing for. I'm certainly not afraid of gaining the information. I guess I would also want the full story as far as what the actual risks are, how much these mutations are involved. I would just want to make sure that I'm covering all of it. But I am open to it.
Okay. No, and I think the best piece of advice that I can give you is to connect you with someone like myself, a genetic counselor locally, and so they could sit down and spend time walking through what Lynch syndrome is, MSH6 specifically, and the cancer risks that are associated. Like your dad said, prostate cancer is one of the lower risk cancers that we tend to see with MSH6, but it tends to be higher risk for things like colon cancer in men. And then for females, we tend to see uterine or endometrial cancer and ovarian cancer. So one of the biggest things that Lynch syndrome is known for is colon cancer. That was really where it all started for that particular gene. And there's a few genes that are associated with the condition Lynch syndrome. And so increasing colonoscopies is really the gold standard of helping to prevent that colonoscopy risk. And I agree with you, Peter, that there's not a lot of prostate cancers that we're finding that are driven from a Lynch syndrome perspective. So my biggest question then is, have you gotten tumor testing? Like, was there anything that looked at your tumor to see if there was an MSH6 driving that as well?
Oh yes, for sure. I've had somatic testing as well, and lo and behold, I've got a BRCA2 mutation somatically. So if those of you listening who don't understand that, it's not germline. It's not passed on to my children, or it hasn't been passed on to me, but my tumor itself mutated to a BRCA2. And that's been useful information because it's helped drive certain therapies for my cancer. My most recent chemotherapy used a platinum drug, carboplatin, which because of the BRCA2 mutation, and hopefully that was successful last year. A couple of things that I've thought about, on this journey. If I had been tested when I was 20 years old, if this technology had been around, I don't know what I would have done with this information, because my sons and my grandchildren are some of the greatest blessings of my life. And, would this knowledge drive me to the point of saying, well, I'm not going to have children. I don't want to pass on a mutation. And I'm so thankful for both my sons and their wives and my 4 grandchildren. It's very special. And so I can't live in a fear-driven mentality that, oh no, what's going to happen with this? Because just as much as we can find mutations, medical science is also finding treatments for these things and being able to manage disease. And I've managed mine for 7 years. And every time it crops up, the high-tech scans they have now and the ways to deal with it are incredible. So yes, it affects my life to some degree, but I'm still here and I'm in the game.
Well, and I think that goes to a comment that you said, Joel, that, we all have mutations and we can't test for everything. So we're all going to have health issues and findings. And, I think one of the really helpful things about knowing these hereditary cancer mutations is that we know we can then start screening and being preventative ahead of time. And so versus we just don't have genes for things like diabetes necessarily to start doing anything preventatively in other cases of health issues. But for certain cancers, we can do screening earlier, we can have preventative surgeries and such. And I think you brought up also a great point about, thinking about, should I have not had children and such? And that's definitely a topic that is brought up and discussed a lot when I meet with patients, because, these BRCA mutations and Lynch syndrome are adult onset. So you're not having issues as children. So a lot of people, once they are educated about their condition, think, well, why would I think not to have kids, because this isn't going to be something until they're adults. And like you said, there's treatments, there's new things that can change at that point. But there are people who have made different choices and said, there's now technology where you can select out mutations before, children are born. So you can do reproductive technologies too. And people have been interested in that. So there's different options that come up when we talk about that topic. And so I'm glad you brought that up to make a point, make a statement there. Because sometimes people think maybe I don't want to have this type of testing until after I've had kids, because I just want things to not have to think about that. So Joel, now that I've given a little bit more information about Lynch syndrome, do you have any additional follow-up questions that could maybe help you or help me to help you for any future, connections and such, or questions?
Maybe they're specific, but I am just curious if there's, say, if my father has Lynch syndrome, what is I don't actually know my mother's genetic testing, but if she doesn't have mutations of her own that I've also inherited, what are the chances of me having that?
That's a great question. So because I don't know your mom's side of the family history, that's an important piece that we would want to gather to make sure that we would not just want to test for what dad's mutation is, but also make sure there's nothing on mom's side that we'd want to address as well. So that's definitely part of the picture. But if we have found that there's nothing on mom's side to address, then it would be a 50% chance that you would have the same genetic finding that dad has that could that puts individuals at risk for things like colon cancer and prostate cancer and other GI cancers. So it's a 50% chance to have the same finding. It's not necessarily that you're at a 50% risk for cancer. There is definite increased cancer risk, but there are people who have Lynch syndrome who don't get cancer, and that's what's so variable and sometimes hard to process, for the fact that the risk range can be very wide in regard to, you know, who's going to get cancer, what kinds of cancer they're going to get, and are they going to get just one type of cancer or multiple cancers or no cancers. And that's the tricky part about cancer and about genetics as well, because we know that there are other modifiers within each of us that either protect or stimulate cancer growth, and we don't know all those factors yet. So it's very hard to give personal risk factor after just saying that we know that you're at a 50% risk to have that mutation because you share half of your genetics with dad.
Well, and another question, I have a biology background. That's what I went to.
Yeah.
Another question that is just really interesting is what is the whole adult onset? Like what is it, say, that suddenly makes it open up? And also maybe I would also say something like this, like, is there you know how there's some mutations that also have a positive benefit? Like, I mean, is there? Yeah, I guess I would just like to know more. You know, there such as sickle cell anemia or something like that, where there is an advantage and a disadvantage to it, depending. So yeah, I guess I'd like to know more about adult onset and what it is, and maybe even the if there's been any history of those kind of things.
So I think the, so to say, advantage piece is that we now have been able to find treatments that people who have hereditary cancer do better on those particular treatments. So that's definitely something that we have found to be an advantage when it comes to having a hereditary mutation-driven cancer, meaning that if you have two men who have prostate cancer and both have a BRCA2 mutation, we know, or one has a BRCA2 mutation, the other one doesn't, we know that the person with the BRCA2 mutation will respond better to certain therapies like what we were talking about with PARP inhibitors. So that's a new therapy that has been doing very well in cancers that are associated with BRCA related cancers. So I think you probably can find some sort of advantage, or so to say disadvantage, if you think about it that way. I guess I haven't thought about it like that before, but that's a very interesting viewpoint. And in regards to the question about adult onset, what I would say is that because you only need one mutation and you have two copies of every single gene, because you inherit half of your information from mom and half from dad, so we only need one copy to have a mutation or a change on it to see these types of hereditary cancers like with Lynch syndrome and BRCA. That other copy is normal, and so that's why we tend to see less of these cancers very, very young, because that copy can still function normally. So if you have one copy that's not working, your other copy functions normally. And that's where things like life and exposures and, you know, stress and other things that we know that can be associated with cancer risk over time, that's when, if once that copy stops working, that's when we can see those cancers kick in. But that tends to not be until a little bit later. So like usually in late 20s and 30s and on. So that's why we have found that these have been more adult onset, because of the way that the genetics works with that piece. So hopefully that helps that. With that said, I want to give you guys, I wanted to give you guys like one more wrap up comment or question, and hopefully then we can move on, and we'll come back to you guys probably later with some Q&A from the group.
I don't, but just so that that wasn't misunderstood, I guess just to throw out, I guess I didn't want to offend anyone that does have a mutation. I was just wondering if there are remote cases where something may lead to a delayed, to the possibility of cancer, but also there's a it offers something, you know, for whatever reason. And I was just really curious about that. So, such as Lynch, I know very little about it except for the name. So you know, and then also, so I was just curious about how that works, but I didn't want to offend the seriousness of.
Oh no, I don't think your comment offended anybody. I think it was a good thought. And I'm happy to share with you some more information about Lynch syndrome if you want, and I can, you know, get your information offline and I can share some more information with you if you'd like. I'd be happy to do that. So Peter, do you have any last minute comments too?
Sure, because this is a fascinating subject and there's more unknown, of course, than there is known. And it's evolving all the time. I was in a seminar, a small seminar with Dr. Oliver Sartor from Tulane several years ago. And he's a prostate cancer oncologist, well-renowned. And he was tracking the various genetic mutations that possibly drive prostate cancer over the age spectrum. And like the BRCA mutation, you know, it might have like a bell curve and so forth coming on at certain ages and stuff. And then he came to the MSH6 gene, which is my mutation, and it was flat at 0 until 66, and then it just shot straight up. And I looked at it and said, "Hey, that's me. That's when I was diagnosed." And I asked him, what's up with that? And he said, "Well, we don't know, but it just kicks in at age 66." And, so there's a lot of mysteries to this stuff, and it behooves us to learn as a patient, as an advocate, as much as possible. I mean, I spend a lot of time advocating for men, not only with prostate cancer, but a number of cancers, but prostate cancer particularly. And I've worked with a couple of guys who had germline BRCA mutations, and I'd go to their oncology appointments with them and kind of lean on the doctor and say, "Hey, doc, if so-and-so is going to do chemo, have you thought about doing this?" And often they won't do it, because they're just generalists and they don't have experience particularly. But you got to get people to speak up, and men particularly don't speak up. Men don't, advocate for themselves. And so as much education as you can put out there. And so I don't harangue my sons, but they know that I'm a letter writer and an email writer, and I don't withhold anything.
Well, keep at it. Because your voice needs to continue to be heard, and that's great in regards to getting that message out. So thank you guys so much for sharing your story and for the questions, and thanks for answering things. I'm gonna switch gears and talk with Karen and Stephanie. Are you ladies here? Hello.
Hi.
Oh, hi there. Thanks for being here. Oh no. Right at the right moment, right? Exactly when you're on, it's like the dog's on, right?
Of course.
Well, with that said, if you want to mute for a second, Stephanie, and figure it out, I'll have Karen talk a little bit and share about her story, and then we'll switch over and let you talk, Stephanie, for a few, and then I'll talk together. Hopefully the dog's in good shape. Hi, Karen.
Hello. I found out that I was positive for BRCA2 mutation in 2019. Stephanie and I
very
also have
recent.
Stephanie and I have another sister. Stephanie and I are positive. Our other sister is not. Our mother was diagnosed with breast cancer when she was 46 in 1998. As far as I know, no one offered her genetic testing at the time. We were very young. Stephanie was 11, I was 13. My older sister was, I think, 16. So no one was really talking about genetic testing to us at that time. Back in 2018, my sisters and I were talking about finally being ready to get tested. And we ran up against well, you guys aren't eligible. we're Ashkenazi Jews. Our mom had premenopausal cancer. We met like 4 out of 5 criteria, let's say. They were like, well, the insurance won't cover it. You can't get tested. So our mom's doctor said, well, I'll test you. So if you're positive, your girls will get tested, and we'll go from there. So our mom was positive. And so then we all got tested right away and found out Stephanie and I were positive as well. Steffi, go for it.
I mean, basically everything that Karen said. I know it was very interesting because our older sister is the one who really, it was her idea first. She said we should really do this, and she asked her primary doctor, who said exactly what Karen said, that, there's no reason for this and your insurance won't cover it. So we found out the only way to do it was if mommy was tested first, and if she were positive, then we could do it. So that was how we found out. I mean, I remember saying to Karen, and she felt the exact same way, that, we just knew. Like, there was no question about it. We just knew that there was no way that we weren't going to have this gene. And it was very surreal. I mean, I remember sitting in the genetic counselor's office, and before we even knew, but Vaya and I, our other sister, went with mommy to get her results. And when we were talking about everything and learning about it, I remember looking at the paper and reading exactly what BRCA2, what this meant at all to have this mutation. And I mean, I remember seeing that pancreatic cancer was part of it, and we were like so in shock that that was even part of this, because everybody knows that's the scary cancer, if you will. And we actually lost our mom last month to pancreatic cancer.
Oh my goodness.
So
I'm so sorry.
Everything has just sort of been a whirlwind, and then knowing that you live with this is scary.
Yeah.
So since you guys have found out, what has changed, especially now with your mom recently passing? Have you decided you're gonna do anything immediately? Screen? What has this process been like for you guys?
I'll let Karen go first.
I actually had a prophylactic double mastectomy with reconstruction in December. So I'm about 4 months post-op.
Wow.
I am very fortunate that, so we don't live in the same state, Stephanie and I. I live in Philadelphia,
Okay.
and so I'm a patient at the Baser Cancer Center, and the doctor, actually my doctor is on the advisory board of FORCE. She is like the person, the go-to for BRCA. So I'm very, very fortunate to be able to get very good care and know what my next steps are, how old I'm going to be when I get an oophorectomy. And she's been very aware of, our mom was diagnosed in mid-December and passed away February 1st. So it was very, very quick with the pancreatic cancer. But so she's aware of that. So she has also already told me what my screenings will look like when I'll start getting screened for pancreatic cancer. So I feel very confident in the care that I receive. And the genetic counselor that I met with was phenomenal. And she actually introduced me to FORCE, introduced me to Bright Pink. So I felt like from the beginning I was very connected to support. So yeah.
Stephanie, do you want to share your journey?
I mean, I haven't done anything yet like that. I haven't met with any plastic surgeons or anything. I haven't had the best experience as far as insurance goes, covering things. I'm only 33. So, I mean, I found out when I was, what, 31 or 32. Yeah. I got my first mammogram and sonogram, and everything was fine. And my OBGYN told me that I should be going every 6 months as opposed to once a year with the gene. So 6 months later, I went back to get my second mammogram and sonogram. And even there at the screening place, the girls were like, "Why are you here so soon? You're so young. This is so much radiation." And I was like, "I have the BRCA gene. I'm supposed to be going, twice a year." And they're like, "I don't know. You should probably get that checked out." And I'm like, "Okay, great." So then I went back for my annual to my gynecologist, and she was like, no, they're right. You probably shouldn't be going so soon. You know, maybe you should just be getting a sonogram. And then to make matters worse, I'm currently fighting with my insurance company because they won't pay for the second mammogram. So I've gotten like 5 bills for over $300 for the second mammogram. And thanks to Karen being so active in Force, she has helped me write a letter to start a claim using Force's template. Because now I'm like, well, now I'm almost due for my next one, and what am I supposed to do? And nobody seems to know what BRCA is, and that's a huge problem. I call my insurance company, you know, I told them at the lab, and I'm like, you know, I'm a BRCA positive person. You know, this is the law, and this is what I have to do. And they're like, what is that?
Yeah. And
That's
frustrating
really
for me. It's frustrating for me to see her go through that as well, knowing like here I am not all that far away from her, and I'm able to get really great care, and I have doctors that do understand what it is, and you know, have really listened to me. And yeah, she goes, well, in the beginning she's like, why are you seeing so many doctors? And I said, well, this is what was recommended to me. So I think the fact that there's not like
consistent
standard, yeah, and not standard of care. I mean, I know I'm a social worker,
and I think that there is, it's just the problem of like education, right? And insurance not being educated, providers not being educated, and so that makes it extremely tricky. And I know that we have some questions in the chat, and some people want to dig more into the insurance piece, so we're going to come back to that for sure. I'm going to switch to my last couple and come back to you guys, because I'm really glad you brought that issue up for sure, Stephanie, and the difference between your guys' care. But I will come back to you guys. Thanks for sharing your beginning of your story, and we'll get some more questions at the end.
Thank you.
Cam and Max, are you guys there? Hi there.
Hi.
Do you want to go ahead and share a little bit about your story and your journey?
Yeah, I think so I'm a medical oncologist by training, and like I'm a BRCA2 carrier. And what I really want to drive home, Lindsay, is like how irrelevant family history was for us. There was no family history. And in part is my grandmother had breast cancer, but it was a stage 1 breast cancer in her 60s, and no one felt this was a family history. And my father was a single child. So when I was diagnosed with 48, no one actually even thought about the BRCA mutation. And only because I'm an oncologist, and I looked at my pathology and I thought, wow, boy, this looks really like a BRCA mutated cancer. I insisted on getting tested, and I didn't really meet any criteria. And that was in 2012, and I did pay almost $5,000 for the test out of pocket. So I think, and really this is over the years, a lot has changed. But for our story, what was really important is that once I knew that I had a BRCA mutation, my father, when he presented with the pancreatic cancer, he was really diagnosed within a couple of weeks, whereas often patients with pancreatic cancer and have small symptoms don't get diagnosed. And then he was treated with the appropriate treatment. He got neoadjuvant chemotherapy because he was a BRCA mutation carrier, and he lived with essentially metastatic pancreatic cancer for almost 5 years after his initial diagnosis. So it made a big impact. And then I'm really excited to have Max here, because I think we have a lot of discussions with patients on like, when should you test your children? Who should do the testing? What's a good time? What to do about it? And my feeling has always been, as a practicing oncologist, I've always felt very strongly, you should let your children decide when they're ready. And typically we say for women, they should get tested when they're 25, because that's when we start acting on it. But then Max, why don't you talk about this, like why you decided to get tested?
So I knew about the basically once I turned 18, I knew about getting tested and what that would mean and the ramifications of that. And I sort of put it off for probably like 2 years, mostly out of laziness. And then when I eventually did take the test, like, I eventually decided to take the test, and it was pretty easy because they can mail you a kit and you can send in a sample and do it mostly online. And so I did that. And my basic thought was that I'd rather know, just on a personal level, I'd rather know that information because I think, at least for me, I felt like the anxiety of the results would eventually start to get better, start to get bigger than the actual test itself. So I just wanted to get out in front of that.
Are you glad that you tested then at this point?
Yeah.
Did you test positive?
Yeah.
So I don't see a lot of young folks who get to test and know that information so young. Do you find, being in college and now knowing this, does it have impact on you now that you know? Tell me a little bit about that.
I mean, honestly, not really. The main thing that was worrying for me was that I have a younger sister, and she also is a potential carrier of this. And in sort of a weird way, the fact that I test positive makes it less likely that she will also test positive, just because of like the statistics of the thing. So that makes me feel a little better about the whole thing. Obviously, she hasn't tested yet, so who knows? But as far as me personally, I don't really think about it often, just because I don't have to do much about it at this point.
I wonder how much, younger individuals in college, if it's something that you think about as dating, or is it something that you feel like it comes up or that you have to disclose or talk through? I think that's always something that comes up when I talk to younger individuals, like, when do I disclose that? Do I need to? Is that something that you've even processed, that is something you feel you need to?
No, I don't think so. I don't think it's really come up or thought about it like that.
Okay.
Yeah.
No, it's interesting. I think everyone views that a little bit differently, and some just feel like it's something that they have to share. And I don't know if it is something you feel like you have to, and it's so personal. So thanks for sharing that with us. So Pam, do you feel that now you've had the experience as a breast cancer patient, a BRCA positive, and an oncologist, your patients must be able to relate in ways that others just cannot. Is there things that you can share with other providers like myself and others out there of what can we do better to be more supportive of patients on the patient side in regard to the BRCA mutation from a cancer perspective? I mean, you just have so much insight now. Please share what your thoughts are there.
And I think what a lot of the speakers before resonated is, and that's really like not necessarily a vote of confidence of my community as physicians, right? It's like what you learn is how often we don't know the whole picture, right? And it's the humbling experience of being an oncologist, how little we actually know. And how it was pretty striking for me in 2012 how little coordinated the care was for BRCA carriers. And I think I got excellent care for my breast cancer, I got excellent care for my ovarian cancer prophylaxis, but then it's sort of like you had to organize your own care, and knowing that this is a family disease, and there's pancreatic cancer risk, and there's prostate cancer risk, and just organizing this is that you have to be an advocate. And for better or for worse, you have to be a healthcare advocate for yourselves. And the reason why I'm here is just to encourage and be grateful to anyone who has been going out and just being an advocate, because just physicians are human beings with all their foibles that everyone else has, and we have a lot to learn. And this is the patient-doctor relationship is a relationship that is very fragile. And so I think there's mutual learning from both sides. And I remember when I talked to the genetic counselor, who's also a good pal of mine, and I said, like, I want to be BRCA tested, and she quoted me the NCCN likelihood why my BRCA test would come back positive. And then when it came positive, she said, "Oh darn!" And I said, "Well, that's very helpful, right?" But that's exactly how we all feel. Like, how many times have you been in life where something completely unexpected happened and then you move on? Right. And Max and I talk about this as like I have always been a big proponent of pre-implantation diagnostics. But I have to say though, like now knowing that I have Max who's positive, I really have to rethink this, because if I'd done this, I wouldn't have Max. And there's nothing in the world that I would give up to not have Max. It's like so that's the difference. And I think Joel said that too, right? It's like, do I really want to know before I have children? And like,
I think it's such an individualized conversation, right? Like, and I so appreciate, Dr. Munster, what you have brought to the field in regards to your thoughts that you have said, and getting that care of all the different cancers and all the different things you need to do is so complex. And if you can get lost as a patient, in the scurry of, I have to go here for pancreatic cancer, I have to do this for that and this and that. And I just feel like we need to keep doing better, and from the hospital side and from a provider side, like, how can we make sure that these patients don't get overwhelmed and lost or have insurance issues and such? And it's 2021 and we still have so much work to do in regards to that. And it is a little bit frustrating when I think about it, but we have come so far with cost and more genes and better treatments and things. So, have to think about both sides of that. I'm curious your thoughts, if you feel like what you went through without really having any family history, do you advocate for people to test anybody who has breast cancer, or anybody who has have genetic counseling? Like, do you have a particular stance and on that topic?
Yeah, frankly, if it were for me, I would test everybody. Because if I had a wish, is like, I just do not want to see another young person walk into my clinic with a big breast cancer that could have been prevented. And that's, when you only test people with family history, we're going to miss a lot of people. And I think I can't speak for Max, because I was, in a way, I learned when I was 46. I went through my younger years without ever worrying, because I was oblivious to the worry. So I don't know if I had known at 24, but I can tell you I'm in my mid 50s and I worry about pancreatic cancer, but I really don't worry. It's like, I know this there, but I don't worry every day. It's like, when I was first diagnosed, I was, but then you move on with calculated risk, and I don't smoke, I don't drink, and I try to exercise, and most of all, I really try to enjoy life, because the one thing you learn as an oncologist, it can be taken away pretty quickly. So I would test everybody, and absolutely everyone with ovarian cancer. The treatments are so different if you have a BRCA mutation or any other hereditary mutation, or even Lynch.
Max, is there anything that you would want to share with young men who know that there's a known mutation, or anything that you feel like would be helpful for me as a provider to share with young people about whether to test or not and being BRCA positive? Is there anything that you've learned or you would want me to share with other young folks?
That just off the top of my head, for me, it was really about like fearing the unknown is kind of worse than like knowing what you're up against. And so like that for me made a big difference. I don't know. I don't have any general advice.
Do you feel, she's your mom, but she has a lot of knowledge in this area. Do you feel like that's helpful to to be able to have that ability, or do you feel like sometimes it can be a little bit harder to go to her for those reasons because she has all that knowledge, plus, you know, she's your mom?
No, I mean, I think it's definitely helpful. I think I probably wouldn't have been as willing to get tested if I didn't know that she knows so much about it, and that she's, you know, dealt with similar things, and that, you know, obviously she's a lot tougher than I am, having already been a cancer survivor. So, you know, doesn't put up with complaining very often, and the woe is me stuff doesn't really fly. So that was a big help.
Well, it's been really great talking to both of you. Dr. Munster, do you have any last words that you want to make sure are heard tonight or shared?
Yeah, I think as I said, I already said, I think everyone should be tested. But at the same time, I also feel like everyone should be tested when they're ready and they have enough support. And I would not advocate as a physician that people test at Max's age. Max was exceptionally mature at his young age, so I was supportive of him of wanting to know. And what I see in younger patients, this hangs over you, right? If you know the mutation in the family, at some point everyone's just so worried that they have it, and it's almost a relief. And then I think the important part is like, and Lindsay, you may speak a little bit to the true negatives. That's a really important part. Like, so what that means, being a true negative, means if our daughter does not have the mutation, she really doesn't have anything to worry about breast cancer. Whereas my other 35-year-old patients in the clinic of breast cancer, no mutation, we don't know what to tell the family members.
Right. No, I do feel like that is, you know, as hard as it is to find, you know, cancers that are BRCA associated and to test other family members who have not had cancer and they test positive, finding people in the family who are true negatives really is helpful and a blessing, and it really does make it all worth it, to where we can tell people and give them that relief that they're at just general population risk because we know what's causing cancer in that family and that person doesn't have it, versus, you know, a 40-year-old with triple negative cancer and we don't know why that happened, and we still don't know. I do see a world where every person who has cancer has some type of genetic discussion. That is my vision, and genetic counselors working with primary care physicians, because that area needs to have some education to where there can be picking up more previvors so we can continue to beat cancer and not treat cancer. So I hope that that's what we end up seeing. But I really want to say thank you guys for sharing your story and for the work you guys are doing. And I'm going to pass it over to Alexa.
Hi, this has been so great. Everybody in our comments have been saying how wonderful all of the stories have been and all of the lessons they have learned. And Lindsay, if everyone could come back on so we could go through a couple questions. But Lindsay, I have a couple of questions from the audience that I think you would be best to answer, if that's okay.
Sure.
So one question we got is, what age should children get genetically tested?
So that's a great question because it varies per, you know, what we're thinking about. If we're talking about a condition like BRCA 1 or 2 or Lynch syndrome or some of the other breast cancer genes like ATM, PALB2, prostate cancer genes can be those as well. We tend to say adult and older. I tend to be very hesitant to test anybody who is not 18, but I do feel like I agree, like what with Dr. Munster was saying, it's still very, very young, because a lot of times we're not implementing any screening or any interventions until 25, or even with men, sometimes and not till age 40. So I will advocate for genetic counseling and having that full conversation with those age individuals, but they don't need to necessarily test. And we talk about a plan of when is right for them at that point. There are some hereditary cancer conditions where interventions can start in childhood. And so it really depends on particular genes when that can be. So there sometimes can be colon polyposis conditions, or I work with a lot of kidney cancer patients. So there's some conditions where we start younger and those types of cancers as well. So I would say if you have that specific question, get connected with a genetic counselor and they'll help you specific to that gene.
So it's a case by case basis, really.
Yes, a general rule is adult or older, but I would say if you have specific questions about what gene you're talking about, I would ask somebody who's familiar with cancer genetics and that gene.
So this actually leads into another question we got. What is the difference, or is there one, of genetic screening and carrier screening when beginning fertility? I guess fertility treatments or any type of family planning.
So meaning, like if you would do cancer screening before you get fertility treatments? Read it. I'm sorry, can you?
Yeah, I can answer that if you want.
Okay. Yes, KK, go ahead, please.
So the carrier screening as a prenatal screening is there's certain mutation, if both parents have it, will lead to pregnancy challenges or condition that can be passed on. The panel is a little bit different because a BRCA mutation, unless both family members have a BRCA mutation and children have a gene from each parent that could also lead to pregnancy loss, we don't actually recommend cancer screening before you go through pregnancy, but the prenatal screening is pretty specific and certain, like ATM is a classic mutation. It causes a pretty severe disease if both parents provide one allele or one type of the chromosome for the baby.
Another question that we have that I'd actually like to throw out to all of our panelists, are there any techniques for getting reluctant family members to consider testing?
This is Lisa Schlager. I'll try to address that. So, I think we all know that family dynamics are very unique. Every family has different relationships, different personalities, and different things resonate with different family members. So, I think providing information in different types of platforms, written, visual, whatever resources you can gather and sharing them with those people can help. Because one reason for testing may not resonate with that individual, but another reason for testing might. I've heard people say, well, I already have cancer, so why should I bother? Well, because you have children, or it could help us determine what treatment might be best for you. Or, well, if I'm going to get cancer, I'm going to get cancer. Well, actually, if you have Lynch syndrome and you're screening regularly, it's possible that we can stop that cancer just by having more frequent colonoscopies and removing those polyps. So, but in the end, it has to be an individual decision. So you can only do so much, and then at a certain point you have to step back and let that individual make their own choice. And when they might choose not to get tested now, but maybe in a few years things change. And I think that
one of the things that I'm curious about whenever I pose that question is the reaction I got. So Lisa, have you found this to be really common in your work with FORCE?
Absolutely. We have lots of people who come to us very frustrated because they've chosen to be tested. They know that there's a mutation and they have family members either older or the same age, cousins, aunts, uncles, children who for whatever reason are hesitant or just aren't interested. And that's okay. It's a personal choice. What we do recommend, though, is that everybody should get educated and make an informed decision. And a lot of people don't even want to see a genetic counselor. But the truth is, just because you go to counseling doesn't mean you have to go forward with testing. Part of the rationale for counseling is to help you evaluate whether or not it it makes sense for you. And so there is value in counseling, even if you don't think you want to test. And I can't say enough about the value of genetic counseling. So, but this is a very common issue, and Force has resources. I know a lot of organizations like us, I believe Sharsheret does as well. But ultimately, you can't force someone who doesn't want to do something. All you can do is provide them with that information and try to let them make those decisions.
Lisa, do you find a gender bias? Do you find men much more reluctant to do any kind of testing?
Absolutely. And I do think it goes back to, especially when you look at families with BRCA mutations, that the women tend to be more affected with certain mutations. So, you know, the mutations that cause high risk of breast and ovarian cancer, women are more motivated to get tested in those families, whereas men, because they have, you know, less risk of male breast cancer, they're not as worried about prostate, perhaps because it's easier to screen for. You know, and men in general, and this is a stereotype, but men in general are often less proactive with their health. So we definitely see biases, but I think there are also biases in the healthcare community. I know for my family, my brother was advised by his physician, why bother testing? We wouldn't do anything differently for you, which is not accurate at all. We have NCCN guidelines that recommend, you know, men start screening for breast cancer with clinical breast exams, or start screening for prostate cancer earlier, or be aware of, you know, pancreatic cancer. But I do think there are some biases in the healthcare system as well. You know, genetic counselors obviously are quite knowledgeable, but when you look at primary care or family physicians, they may not be as knowledgeable. And I think we have to do a better job of educating them on the value of testing for both genders. And especially when it comes to some mutations like, you know, Lynch syndrome genes that absolutely don't discriminate when it comes to the cancers. I mean, colon cancer affects men and women.
So Lisa, I would love to get back to you because you have a lot of experience in insurance issues, like we were talking about with Karen and Stephanie.
Yeah.
We have a question that came in that I think Lindsay should answer. And Lindsay, I'm so glad that you're here, because I think sometimes people might hear genetic counselor and be a little scared. And you know, you're a person, and I think that's the thing. What Lisa just said, you can go to genetic counselor and you don't have to get tested. You can take that first step. And I just want to ask, just so people know, have you had people come to you and made the decision to not get tested?
Oh yeah, all the time. And sometimes we talk about a plan. You know, right now, I used to see a lot more breast and ovarian cancer in the beginning of my career, but I see more prostate cancer patients now. So it really just depends on where a man is in his process. So sometimes I see a patient who just was diagnosed and it's just, they can't wrap their head around it, because for men with prostate cancer, there's no immediate changes, that which can be different when it is with women, because some women would decide that they may want to remove the other breast at the same time. So sometimes they'll say, you know what, how about I call you in like 6 months and maybe we'll do it then? Or they're like, you know what, I'm just not ready for this at all. Sometimes I see children of patients who, once we have a conversation, they say, oh, wow, I really do need to think about life insurance. And I do really want to get some other things in play. I'm so glad that we had this conversation just to educate and talk through it. And so then I can get some other things figured out and make a plan and come back to this. So it's really, genetic counseling is just really about educating. And a lot of times the appointment is either free of charge or covered by insurance too. So there's always this concern about getting billed for the genetic counseling appointment. And really the cost mostly comes from the genetic testing, and that's not decided until, you know, at the end, or if the patient wants to do it at that point.
So what I'm hearing, just so our audience can hear, you would rather somebody come just talk to you and keep the lines of communication open, even if nothing else happens And I think that's great, because I think some people feel like you have to get testing. And I think that's a conversation we can have with some of our family members, that you can go and get more information, and it's not a scary experience. So we had
really, oh yeah.
Go ahead.
I was just gonna say, really, the goal of genetic counseling is just to educate. So it's not about the testing, it's about doing what makes sense for that patient.
Perfect. That's a great answer. So we have a question. Is it more common for people with certain blood types to have a genetic mutation that could cause cancer? Or is there no connection between blood type and genetic mutations?
There's no connection between blood type and cancer genetic mutations, no.
Okay, perfect. And Lisa, if you could talk some about the insurance challenges.
Yeah, so I actually was interested when I was listening to Stephanie talk about how this was legally supposed to be covered, and unfortunately, that's not the case. A lot of people have the misunderstanding that under the Affordable Care Act, all preventive care is supposed to be covered, and that's not true. Only certain preventive care is covered under the Affordable Care Act at 100%, and those are things that the U.S. Preventive Services Task Force has published guidelines around, and they are typically services needed by the average risk population, which is not our community. So you're talking mammograms for women starting at age 40, for instance, or colonoscopies starting at age 50. When you're talking about, and even genetic testing for certain mutations, genetic testing for BRCA mutations is supposed to be covered in only women, not men, because the task force only addressed women in their guidelines at no out-of-pocket cost. But that doesn't mean that testing for other mutations has to be covered. I will say genetic testing is very affordable these days. You can get testing for as little as $50 if you have a family member with a known mutation, or $250 for multiple genes. So the cost of genetic testing should not be an issue at this point. Where we see issues is really the cost of the follow-up interventions. So screening. So Stephanie, you've had trouble getting your screenings covered. I'm not sure how old you are. According to NCCN guidelines, women with BRCA mutations should be having MRIs starting at age 25, breast MRIs, alternating with mammograms. Unfortunately, health insurers are not required to cover those. The majority of them will cover them, but a lot of times they might be applied to your deductible. So that doesn't mean it's not covered. It just means that it's considered like, you know, an out-of-network service or a non medically necessary service for the average risk population. This is really a huge issue we see. Also for Lynch syndrome carriers who need colonoscopies starting between ages 20 and 25. And those are recommended every 1 to 2 years. So unfortunately, we do see huge out-of-pocket costs involved with some people just based on their insurance, and it varies greatly. We are working on addressing this with state-level legislation, but as you said, we also have appeal letters that can be very effective, and they're downloadable from our website. But nationally, we're working on Medicare legislation right now to remedy this issue. It'll be introduced later this month because Medicare does not cover preventive care for a lot of people. So we're working on that. But as far as the private insurance goes, it at this point needs to be a state-by-state effort. And I'm happy to talk to individuals about what their state requires or what their insurance should and should not cover, and how to address that if there are extensive out-of-pocket costs. There are some sources of assistance out there, not a lot, but we have been pretty effective at getting insurers to yield and give higher reimbursement rates for certain screenings as needed. So
Lisa, what I'm hearing is this is very common.
Absolutely, and it's insanely frustrating for everyone involved, because you think I'm high risk, I should be able to get these things covered because I'm trying to stay healthy. And unfortunately, our health system is not set up that way. And we're working on it, is all I can say. But FORCE absolutely provides assistance in these areas as far as appeals and finding resources to offset costs if needed.
However, I would like to add that for people with hereditary mutation, do not go on high deductible plans. This is really not
Absolutely.
a good, and I think that's what people don't understand is like if you have a high deductible, essentially a healthy person with a high deductible will pay everything out of pocket.
Right. We advise all of our community members to go for low deductible, high coverage, more premium plans. Ultimately, it pays off. We've actually done cost comparisons, and you might think you're saving money with a high deductible, but in the end, because of all the screenings that people with hereditary risk have, really need to undertake, you will ultimately pay more out of pocket versus paying a little more each month for that better plan with a lower premium.
So Lisa, here at ANCAN, and we also have a Canadian in the room, we have a lot of Canadians in our community. Is there anything that you know of that they should know?
My understanding is with the Canadian system, if they do your testing and you're found positive, that they offer coverage for all of the screenings and necessary interventions. I know Canada will actually cover prophylactic mastectomies for women who are interested as well. So for those Canadians, if you have a known mutation in the family, they will pay for the testing, and you might have to wait, but they will also cover the needed increased screening or other interventions that are indicated.
And can Canadians reach out to FORCE as well?
You can. I will say we're not the experts on the Canadian system, but we have lots of resources and can connect you also with Canadian organizations who may be able to help.
So we have a little bit more time left. I'm very curious, do any of you panelists have any questions for anyone else in hearing each other's stories?
Yeah, I have a quick question. So most cancer screenings are pretty much non-invasive, a blood test, a mammogram, whatever. Colonoscopies are higher risk. And when I was told, go for every 2 years, first I was told to go every year. And then I talked to a surgeon and they said, no, let's do it every 2 years. Because you can puncture you can do all kinds of things. It's not just a simple 10-minute procedure, which is, I know this is Cologuard stuff, but that's got some false positives and false negatives and so forth. Has there already been any inroads in doing that for Lynch syndrome people, making things easier?
So I think the problem with the colonoscopy is it's just so incredibly effective, and for two reasons. So you can see a colo may only give you if you have an active problem with bleeding. The colo test, the colonoscopy can actually see a polyp, and a lot of the polyps are actually benign. But if we see a benign polyp, then we change the interval of the colonoscopies and we take a biopsy of the polyp. And so not only do we see a lot more, what we do about it is also much more impressive. So I think in my estimation, as a friend of mine says, that there's two things that really save lives. One is the seatbelt and the other one is the colonoscopy. And that's probably true. Colonoscopies are really, really effective.
Oh, okay.
That's a great question too.
I have a question for Joel about the reluctant testing. So the question was, how do you get a reluctant family to test? You're kind of like a family member who has not been tested. It's like, what's your take?
Right. I'm pretty neutral. A lot of it, I've learned a lot in this past hour and a half, for sure. And I'm maybe more pro-testing than I was 3 hours ago. I guess I've been to doctors and I actually posed that question that my father has a hereditary link, possible hereditary link to the cancer. Do you think I should get tested? And doctors that I actually respected, and they were like, oh no way. So I've heard. So I guess so I guess I'm soaking it all in and trying to understand why you wouldn't get tested. And I also have I have a brother, like my father said, who isn't so, who I really I respect a lot, and I respect their reasoning, and isn't so keen on getting tested, and and feels that they're doing everything that they can anyway. So the testing would just be a moot point, and maybe eventually they will. So anyway, I guess maybe it's a long-winded. I think that good reason is the best, and I think good education of the benefits of being tested are there. Yeah, I'm more. I think at this point I will actually ask a doctor and just see how the process goes for testing here, and see how that resonates. You know, yeah, does that answer the question? I think just good reasoning.
I will. I'd like to jump in, Joel, and I think your point about your brother not doing anything differently, and he's already doing all the things he should be, which is fantastic. And actually, I think that is one option. If you just choose not to test, but you treat yourself like you have a mutation and you do those additional screenings, that's great. Unfortunately, in a lot of cases, insurance will not cover those additional screenings unless they know you have a mutation, or unless they know that you have that added risk. And so that is actually a driving factor for some people to get tested, because your insurance may not pay for you to have that colonoscopy every other year. If they don't know.
Quite frankly, if you don't have a risk, you shouldn't have that colonoscopy.
Absolutely right. Yes.
I mean, doing an annual colonoscopy in someone who's not at risk would really be malpractice, because then you have all the risks and none of the benefits, and not just from a financial point, but from a medical point. That's really bad. And why would we start a person with mammograms and MRIs twice a year for someone who doesn't have the mutation? That would not be. I mean, the beauty of having a mutation, the only good thing, you asked me what's a good thing about having a mutation, you actually know whether you're at risk or you're not. And it's very clear, you're at risk or you're not at risk.
It helps inform what you should be doing or shouldn't be doing, because if you're negative, you don't have to do all those extra screenings. But if you have that mutation, then you can use that information to be proactive as you see fit.
Well, I have Canadian genetic counselor friends, so if you want somebody in Canada, I can connect you so that you get a straightforward genetic discussion, and in case some of the physicians you've been going to aren't as up on that knowledge, so I can connect you with somebody in Canada if you would like.
Yeah, that would be fantastic. I'll check into it. Another big question is how is the statistics on the risks? I mean, coming in as someone that really knows very little, at this point, I kind of counseled myself that there's a possibility that I will end up having similar cancers to my father, and I've kind of made my peace with that. And there's a possibility that I won't, and I've made my peace either way. But just understanding the risks, and also what my dad brought up about the risks of actually doing lots of testing and the types of testing, it just seems like it's good to be educated all around on that. Like, say if you don't have a genetic mutation, that doesn't mean that you won't get cancer. And so it just seems to be, it seems smart to be realistic about what the risks are, and how much you're actually in the clear, and all of that.
And also how important genetic counselors are, Joel. I think that's one of our biggest takeaways, that they're such a great resource for us, and that they can answer these difficult questions with our medical history too. I would like to give a humongous thank you to everyone here. I feel like this was so informative. I feel like this is going to spur a lot of talks, people's own talks. And I thank you all so much for sharing your stories and sharing these invaluable resources. So Rick, can you close us out?
I can close you out, and I just want to endorse Alexa's gratitude. This has been just terrific. I sit here thinking, I wonder if parents or siblings are hearing things they haven't heard before. That's always the thought that runs through my mind. So I think maybe for Peter possibly. I'm not so sure for Pam, but I think for Peter it's been very enlightening. So yes, we are tremendously grateful. This webinar will be recorded. It has been recorded and will be available. Hopefully it'll be up by tomorrow. If you signed up and registered, you'll get the link. If not, you'll find the link on our YouTube channel. You'll find the recording on our YouTube channel, and we'll blog it out through ancan.org. I think our next session is going to be an immunotherapy session with Larry Fong, Pam. So I'm a huge fan of Larry's for many years, and we will be having some more general sessions later on in the year. We are firming them up, and we will publish a full schedule pretty soon. So thank you, everybody. Thank you for your time. Please follow up if you need connections to anybody on the panel. Follow up with Alexa, and she'll make sure that you get the email address. It's alexa@ancan.org, and I think that's it, right, Alexa? Can I go now?
Yes. Thank you.
Thank you.
Thank
Thank you,
you.
everybody.
Good night.